All right, we're all set.
Perfect. All right. So I'm Dr. Henson. I am a pediatric preventive cardiologist at Cincinnati Children's. And then I also have my email available for if anybody has questions after this, feel free to reach out. Um, but the talk today is early risk detection and long-term cardiovascular impact of pediatric hypertension. So typically for preventive cardiology, we tend to do more lipids, but I've been cross-trained to also do pediatric hypertension. So I'm really excited to give this talk to you all today. The only disclosures I have is I do work with several commercial companies as a consultant for AstraZeneca, and then also Esperion. We've done some clinical trials with them. But none of that should have any issues or have any issues with the CME policies. And then by the end of the session, you all should be able to apply the current pediatric hypertension guidelines to classify blood pressure and identify abnormal readings in children and adolescents. Evaluate elevated blood pressure in children, including appropriate follow-up, initial workup, and use of ambulatory blood pressure monitoring. And then finally, recognize long-term cardiovascular implications of high blood pressure in youth and the role of early lifestyle interventions. So a lot of times as pediatricians, we think about cardiovascular disease as an adult problem. And a lot of adults and parents also have this mindset that cardiovascular disease is an adult problem. But hopefully by the end of this, you all will understand why I'm so passionate about treatment early on. But just to start with some statistics. So the Global Burden of Disease Study is a global research program of disease burden that assesses mortality and disability for major diseases and risk factors. So it started in the 90s and continues on through today. So they collect information every year. Cardiovascular disease burden from modifiable risk factors continues to increase globally and continues to be high, especially in America. What you see here, though, is specifically for Ohio. So the leading risk factors for Ohio, based on the 2021 rankings, number one is overweight and obesity, followed by high blood sugar, smoking, drug use, and then high blood pressure comes in at number 5. Additionally, the life expectancy in years is better in some areas than others. As you can see, there are some green to blue areas on this map, which is better. But we're really seeing a lot of orange and even dark orange in some cases in South Ohio. And so that's how long people are living from 70 to 85. Ideally, I would love everybody to live well into their 80s and 90s without any heart disease. And then lastly, the obesity piece. So by 2050, there's a projection that 61% of young people, so this is our population now, will be overweight or obese in Ohio. So again, this is why we need to target during childhood, because we know, and I'm going to show you some data to show that these risk factors definitely track into adulthood. So specifically as a cardiologist, my biggest passion is the vasculature and the heart. Well, the vasculature affects the heart, so that's why I care. But pediatric hypertension is about 3 to 5% of children and adolescents. So not super high, but still up there. And then in terms of the vasculature, we do know that vascular aging actually begins in utero or at conception. And tracks into adulthood. And there's been a lot of good studies to show that the more risk factors for heart disease that a person has, the acceleration of vascular aging increases as well. So we really want to target these risk factors and ideally prevent them from ever starting, so the primordial prevention. And then when we identify them, actually treating primary and secondary causes. Prevalence rises for pediatric hypertension in adolescents. those with higher overweight and obesity tend to have higher rates of hypertension. It's often asymptomatic and unrecognized in our population. And then, like I said, just early detection and intervention can lower long-term cardiovascular risks over time. There are non-modifiable risk factors as well as modifiable. Childhood obesity is going up, insulin resistance is going up, metabolic syndrome risk is going up, and all of these contribute to higher blood pressure. So understanding these risks and how we can start to intervene is super important. And obviously, you can't change a kid's age. You can't change their genetic sex or genetics in general from a family standpoint. And then also just in general family history, where you're at, socioeconomic, all of those things factor in for a lot of these cardiovascular risk factors. In terms of modifiable risk factors, we do know that a lot of kids have not the best diets. They score in terms of the American Heart Association Essential 8, which is like the 8 modifiable risk factors that we can target for healthy lifestyles. We know that kids' diets tend to be poor. So a 20.5 score out of 100 is not great. So you want their score to be high for like really good nutrition. So they score pretty low in diet. Physical inactivity is also another area that is pretty high in kids, especially with screen time and everything else. Most kids are not getting the exercise they need. Additionally, sleep is becoming a much bigger issue in our pediatric population. So understanding how sleep can also be linked to hypertension, obesity, and inactivity, working towards improving that is important. Thankfully, nicotine exposure is stably down trending, but still about 1 in 4 high school students report ever using tobacco products. So that's still fairly high for what we know about it. And then we know rates of obesity are going up, high blood pressure, high cholesterol, prediabetes are all things that contribute. Early detection does matter because pediatric hypertension has been shown to start affecting our organs, especially the heart. So one thing we will look at in pediatric hypertension is whether or not the heart is enlarged in those with confirmed high blood pressure, because there is about a 20 to 40% chance of having increased left ventricular hypertrophy when we have hypertension, and this is in youth. It also increases arterial stiffness and then can lead to early vascular remodeling, which over time leads to cardiovascular disease in later adulthood. Additionally, there's been a lot of great long-term cohorts to show that childhood blood pressure predicts adult risk. So childhood blood pressure, vascular aging, vascular events have all been linked to childhood blood pressure. So on this table, I pulled out the high cohort studies that began back in the 80s to track cardiovascular risk in children. So some of the most popular ones or the most robust ones are the Muscatine study. So they looked at blood pressure trajectories into adulthood and also found that screening identifies future risk. The Bogalusa Heart Study really was able to show that risks found in childhood linked to early arterial changes in adults. The Young Finn Study found that risk reduction slowed arterial aging, so treating the risk factors made arteries better over time. The PDAY study was really looking at autopsies in young people, and they were one of the first studies to show that increased risk factors or the number of risk factors led to increased advanced lesions in the aorta and coronary arteries in young adults and late teen years. And then the CDAH study looked specifically at blood pressure and obesity. And they found that those both tracked into adulthood in terms of obesity, hypertension, and then also vascular stiffness. And one of the most exciting groups coming out is the I3C consortium. This is a collaboration among a lot of these pediatric cohorts. And most of these people are now in their later decades of life. So this is really one of the first groups to show hard outcomes based on what childhood risk factors were. And one of the findings was that childhood blood pressure predicted hard events later in adulthood. So long story short, elevated blood pressure in youth is an early cardiovascular risk signal and is not benign. In terms of, well, what blood pressures are we really looking at and which blood pressures predict adult cardiovascular events? So on this table, I really wanted to point out that normal blood pressure just gives baseline risk for everybody. But interestingly, high normal and elevated blood pressure actually increases the cardiovascular events 50% in adults. And again, these are blood pressures we aren't treating yet. And then if you have hypertension, that increases the risk in adulthood by 2 times. The hard cardiovascular outcomes that were looked at in these studies were coronary heart disease, stroke, heart failure, and even death. And then there's also been some subclinical cardiovascular looks and to show that left ventricular hypertrophy was higher, increased carotid intima media thickness, which is a marker for atherosclerosis, and then also arterial stiffness, which is a combination of atherosclerosis plus just arterial aging over time. So again, even high normal blood pressure in youth can increase their lifetime cardiovascular risks. In terms of risk factor screening, so this is really where, the primary care, the medical home is so important. Screening starts there. In terms of blood pressure screening, the US guideline recommendation is annually, beginning at the age of 3. Earlier, if they have other like high risk factors like kidney disease, heart disease, things like that. However, in practice, a lot of times it's about 30 to 50% of accurately measured blood pressures in pediatric settings. 24-hour blood pressure monitor or ambulatory blood pressure monitor is the gold standard to confirm hypertension diagnosis. However, it's very limited in availability. A lot of places don't have access to this. There's limited ways to measure blood pressure outside of the clinical setting, and we know that clinical blood pressures are like the least accurate in terms of what's truly going on. So that one's hard to do unless you have a dedicated hypertension team in your area. BMI, so height and weight, yearly should be done at every well-child check. Surprisingly, in the US, only about 50 to 70% is actually documented. Additional risk factors, so insulin resistance, type 2 diabetes, screening in overweight and obese risk population, only about 10 to 30% actually get screened. Sleep for duration, sleep apnea is rarely assessed, me included. I do a horrible job unless I'm doing my obesity clinic. It's really hard to track this and actually to get accurate sleep records on these people. And then lipids, universal screening again is 9 to 11, 17 to 21. Less than 20% of kids in the US are actually screened universally for lipids. So this is just to show that, again, everybody's got a lot going on, but we need to be doing better for these kids. Oops, sorry. In terms of who and how to get a good blood pressure, this is probably one of the most important things. Feel free to take a screenshot as long as you cut my kids out of it or don't like use my kids' pictures for anything. But getting an accurate blood pressure, it can be very tricky because of the busy settings of offices where the kids are. A lot of times people are rushing in and out. If they have to get vaccines that day, everything is going to start affecting, the blood pressure that you get. Ideally, they should be not eating, drinking, no caffeine. But again, that's an ideal world. Most kids, we can't guarantee that, but about 30 minutes before. Sitting quietly for 3 to 5 minutes in a chair supported with feet flat on the ground. This is probably the biggest thing I see in not just pediatric clinics, but adult clinics too, that people just do not do this. They usually get them up on the exam table and then take the blood pressure. Um, but this is one of the easiest things to implement in your clinic to get better blood pressures. And then ideally a comfortable temperature. They should have their arm not with anything. It should be a bare arm, heart level with the arm, correct cuff size. Listening or auscultation is the best method. Obviously, if your clinic uses automated devices, that's fine. But if you get an abnormal blood pressure, really should be checking with an oscillatory pressure as well. Additionally, in peds, it's can be uncomfortable, especially in our obese population, to get blood pressure. So one little trick is that you can feel the radial pulse. And when you are pumping up the cuff, once you lose that radial pulse, then you only have to inflate about 20 to 30 above that to get a good blood pressure. And that can ease that overinflation pain that some kids get, which can raise the blood pressure. So that's just one trick that you can do. And then if it's abnormal, you should be getting at least 2 to 3 readings and then taking the average of those. The 2017 guidelines that came out specifically for peds redefined categories, and then more recently they came up with the new blood pressure guidelines. Not much has changed in the peds aspect of blood pressure management, but the main things that came out of the 2017 guidelines was aligning blood pressure categories with the adult categories. So now we've got elevated where it was pre-hypertension before. If you're elevated, blood pressure, lifestyle counseling is what we recommend next, and then repeat a blood pressure at 6 months. If it's persistently elevated, reinforce lifestyle after additional 6-month follow-up. If it's still elevated, then that's when we recommend evaluation and making sure there's no masked hypertension. For stage 1 hypertension, you want to definitely confirm that with auscultation, and then repeat that blood pressure in about 1 to 2 weeks. Persistent stage 1, evaluate, monitor, 24-hour monitor if available, and then 3-month follow-up if, with lifestyle changes is appropriate. And then stage 2 hypertension, you want to definitely confirm, make sure there's no symptoms, repeat after about a week. And then if still stage 2, then that would be when you would evaluate and refer. And then the last thing I just want to make sure is to obtain upper and lower extremity blood pressures is important once you identify an abnormal blood pressure. The main reason for that, we want to make sure there's no coarctation. So feeling for femoral pulses, upper and lower extremity pulses is so important. But also once we've got an abnormal blood pressure, making sure there's not any changes in lower blood pressure and upper extremity blood pressures. The initial evaluation that can be started even before referral is a good history. So a lot of things you can tease out from the history. So prematurity is a risk factor for higher vascular stiffness, higher blood pressures in general, and then the potential for renal artery stenosis, especially if they had any kind of umbilical artery lines. Sleep apnea, medications that they're on. There's a lot of medications that can raise blood pressure. Diet, specifically sodium intake. Unfortunately, in the US, just about everything that comes in a package has extra salt in it. So that can be a super easy step before they even get into hypertension clinic, is just to educate on looking for how much salt they're getting in their diet. And then family history is really important as well. From a lab standpoint, really wanting to get a baseline urinalysis, a BMP just to check electrolytes, renal function, lipid panel, just to rule out other risk factors. And then if their BMI is elevated, you want to work up those related comorbidities for risk factors like insulin resistance, thyroid. A CBC can be super helpful as well because if there's anemia, that might point you more to like a kidney issue or an endocrine issue. So just making sure that we're not missing any comorbidities. In terms of exam, good documented BMI, blood pressure in the arm and leg, a good cardiac exam, and just in terms of making sure you're not hearing any extra weird heart sounds. With co-work, you can sometimes hear an abdominal bruit. There can be AVMs, other issues that you might be able to hear on an abdominal exam. And then any endocrine signs to point you in multiple directions in terms of, thyroid or insulin resistance, things like that are also important to document. Like I mentioned earlier, for confirmation, the 24-hour blood pressure monitor or ambulatory blood pressure monitor is the diagnostic standard or gold standard. This confirms hypertension. It can also help us tease out like white coat hypertension, medication-induced hypertension, if there's any other issues in terms of mass hypertension, et cetera. It also can help guide targets as well. So a lot of times we will repeat these monitors about a year or two after starting blood pressure medications to make sure that we are meeting targets. It's really important in specific populations like kidney disease to make sure that we are dropping the blood pressure appropriately. And then when to get a monitor, so those elevated blood pressures at that year point to rule out mass hypertension, stage 1 hypertension on repeated visits. If you're concerned about white coat hypertension or mass hypertension, that's a good time to get it. And then there's certain higher risk populations that it is recommended they at least get ABPMs during their adolescence periodically, and that's going to be anybody with chronic kidney disease, diabetes, obesity, post-caloric repair, or if there's any like discordant clinic blood pressure that you're worried about, maybe a caloric or something like that. Home blood pressure is something that's used a lot in the adult world. We don't typically use it for diagnostic, but it can be helpful if you make sure it's reading accurately in kids as something to help when they're outpatient. But like our earlier slide showing to get a good accurate blood pressure, most people are not necessarily going to get the best blood pressures at home, but it can be helpful, especially in certain populations. The one caveat being that a majority of the devices that are commercially available are validated in adults only. So the only pediatric ones that are on the market is going to be the Omron home blood pressure monitor and LifeSource if you have a slightly larger adolescent or somebody who has a big arm. The LifeSource comes with a larger cuff. So those would be the two if you're going to recommend for a pediatric patient. Those are the ones we tend to go with. And wrist cuffs are awful. So if somebody comes with a wrist cuff blood pressure, it's not helpful. In terms of hypertension in athletes, this is something that is loosely addressed and not a whole lot of evidence behind it outside of it is a risk factor. And it also comes up a lot on the pre-participation exam questionnaires and such. So if there's an elevated blood pressure, this can be common in strength sports. White coat hypertension actually tends to be more common in athletes, and that's where a 24-hour monitor can be helpful. In terms of evaluation, you want to confirm that the blood pressure was taken accurately. 24-hour blood pressure, like I said, can be super helpful. In certain types of athletics, there is the whole athlete's heart phenomenon versus LVH from hypertension or a higher BMI can sometimes be hard to tease out. But that's where getting evaluation by a hypertension or cardiac specialist. In terms of sports heart participation, stage 1 hypertension with no target organ damage is usually cleared for sports. Stage 2, or if there is LVH on the echo, then they should be restricted from high static sports until their blood pressure is controlled. So on the right here, you can see the high static sports are going to be ones that increase your blood pressure load. And then the dynamic sports, the BP load is lower, so not as risky. For me personally, because I'm getting the echoes, even if there's LVH, as long as there's no outflow tract obstruction that could lead to like the coronaries not functioning properly, as long as I'm starting blood pressure meds, a lot of times I will clear them to go back to their exercising because we know that that can be very helpful in lowering blood pressure over time as well. So bottom line, if they have stage 1 hypertension, they can still participate, but in the process of getting them referred and into a specialist to confirm and do the workup. And then just some pearls to take away. Most elevated blood pressure is white coat hypertension in athletes. Repeat blood pressure plus 24-hour monitor for diagnosis, and then really going to need an echo plus a history to distinguish athlete's heart versus LVH. In terms of medications associated with hypertension, there's definitely some common medication triggers. So stimulants tend to be the most common things I see when I get referrals for hypertension is my ADHD patients. Some hormonal medications can also increase the blood pressure to a degree. Immunosuppressants, so in our post-transplant population and other autoimmune populations, some of these medications like Tacro and cyclosporin and steroids can increase the blood pressure. Decongestants, because of the vasoconstriction effect of them, can increase the blood pressure. And then high-dose beta agonists as well. There are some neurologic and psychiatric medications like SNRIs and bupropion that can increase blood pressure. And then some of the other over-the-counter things are NSAIDs that we want to be careful, especially in our athletes, for taking NSAIDs, making sure they stay well hydrated. Erythropoietin can also increase it. And then any teens that you suspect substance abuse, make sure you're screening that out because those things can also raise the blood pressure, especially if you work in an ER. That's a great thing to screen for in our adolescents. Back to ADHD medications and blood pressure, I get a lot of questions. I get a lot of referrals. People hesitant to start ADHD medications if the blood pressure is elevated. So I wanted to provide some myth versus fact information for you all. One of the myths is that stimulants increase hypertension significantly, but the reality is the bump from stimulants is actually fairly small. Most people only see about a 2 to 4 millimeter of mercury increase in the systolic blood pressure and then a 1 to 2 bump in the diastolic pressure. I also get this a lot, that they are supposed to stop stimulants if the blood pressure rises. Most children remain normotensive on stimulants. So if you're going to refer a child because their blood pressure is high after starting the stimulants, keep them on it so that when they go to the hypertension clinic, you're not getting the hypertension specialist getting a blood pressure off the stimulants being normal. Then it's an extra visit for the families and everything else. Whereas most of the time, even if the blood pressure is high, we've got time to tease it out if they're asymptomatic. So just keep them on the stimulants, get them in to get a good normal or a good blood pressure measure, potentially 24-hour blood pressure monitor. And that's going to be a lot more helpful in the hypertension setting than if they go off the stimulants and are completely normal. Last myth, blood pressure elevation is medication related. A lot of times it can be due to other causes. Sometimes I get patients who are on multiple medications. It's not actually the stimulant causing the blood pressure, but they're clonidine from sleep. plus an SNRI. All of those things can change sympathetic tone and be a cause for elevated blood pressure. So making sure that we're not missing other secondary causes or even primary central hypertension in some of these adolescents is going to be important. So again, bottom line, don't stop stimulants solely for blood pressure elevation, especially if you're going to send them to hypertension clinic. And then monitor the blood pressure periodically and look for other causes if there is a high blood pressure. There are secondary causes of hypertension. So in our younger kids, a majority of high blood pressure is due to renal disease. Not always, but a majority. Stage 2 hypertension, think about coarctations or other things that would raise the blood pressure a lot higher. Most kids don't start out at stage 2 hypertension without there being some underlying cause. If it comes on all of a sudden, or if there's severe hypertension, endocrine should really pop up to the top of your radar or list of differential diagnoses. So thinking thyroid or some other kind of like, even though it's rare, they like to test about it, but PHOs are the other pheocytochromatoma, or cannot speak today. But yes, think of other endocrine hormonal issues. And then lastly, abnormal exam or labs, especially sleep apnea, obesity, things like that, or skin findings, just looking for those other secondary causes on your exam. There are some high risk populations. These are the ones that we definitely want to be getting blood pressures earlier in, based on age, plus more frequently. So obesity being probably the most common thing we're going to be seeing in clinics, chronic kidney disease, congenital heart disease, diabetes, accelerates vascular disease. So those patients you definitely want to be keeping in track of their blood pressures. Prematurity, like I mentioned earlier, their vascular development is just not normal, plus the risk of renal artery stenosis if they've had any lines. Sleep apnea is a very common contributor to elevated blood pressure in a lot of our adolescent patients. Cancer survivors, especially if they've received cardiotoxic therapies and any renal injury. And then transplant recipients due to the immunosuppressants and renal effects of a lot of the drugs and just inflammatory processes of transplant in general. In terms of management, so once we've diagnosed, what are the next steps? So if I'm going to start a medication or confirmed hypertension, I will usually get an echo. The primary thing I'm looking for is structure and function, and then left ventricular mass, because that is one of the subtle but things that we can see in pediatric patients. If we're going to start medications, if they're symptomatic, definitely for any stage 2, if they have LVH or other issues, you're not, a lot of the other target organ damage, at least in kids, we're not going to see, like you can get an eye exam, but at their age, it's unlikely that you're going to see any retinal changes. So really the echo is the biggest one. Chronic kidney disease or diabetes, we definitely want good control of blood pressure in those, or if there's persistent stage 1 hypertension after 3 to 6 months of lifestyle changes. Blood pressure targets, we want to ideally get them below the 90th percentile. So less than 130 over 80 is going to be stage 1 hypertension for 13 and older. 90th percentile for that age is actually going to be 120 over 80. So really shooting for trying to get below that, but you don't want to over medicate either. So a lot of times in clinic, I shoot for at least getting them less than that stage 1. And then once I get an ambulatory blood pressure, if they're still kind of in that elevated range, I might bump up their meds again. But most of the time in clinic, you're going to shoot for at least less than the stage 1 range for now. In chronic kidney disease, the blood pressure target is really based on 24-hour blood pressure monitors, and they really look at the mean arterial pressure and shoot for less than 50th percentile there. For all patients, lifestyle, because diet is, especially in kids, one of the worst in the life essential eights. We want to try to really target heart healthy diets. For hypertension, it's really still kind of the DASH style diet of reducing sodium, ideally to less than 1.5 to 2 grams per day. There's slightly adjusted goals based on age, but 1.5 to 2 is a reasonable target once you identify hypertension. And it's actually fairly hard to do if you're not making your own food and not using anything out of a can or a bag or getting food out, which most families don't. So that is one of the key things that you can target to start. And then increasing activity, weight management is important, and sleep optimization. In terms of future directions, there's a lot coming out about risk-guided treatment based on target organ damage, plus emerging therapies for resistant hypertension, a little bit more in the adult population. We don't see a whole lot of resistant hypertension in the pediatric population, but there's a few cases where that can be present. And then I also think based on some of the long-term cohort data that's come out is we're going to probably start targeting much lower treatment ranges in the future and potentially even starting meds earlier. Um, so overall goals, confirm your hypertension, main thing, lifestyle, prescription, diet, exercise. Medications, if they're stage 2, target organ damage or high risk, and then shooting for good blood pressure targets once you start those interventions is the goal. For the antihypertension medications, there's several classes of antihypertensive meds. ACE inhibitors, ARBs, calcium channel blockers are all pretty much equivalent for in terms of the guidelines for pediatric treatment. They all come with some pros, with some key considerations. So for ACE inhibitors, the pros is that there's a lot of pediatric data out there. It's renoprotective. It's only dosed once daily. It has some cardiac and vascular remodeling effects, which is really nice as well. Rarely, people can develop a dry cough. It can also increase potassium and creatinine. But with peds, we start at low doses, and a lot of times we're on single therapy for blood pressure. So the electrolyte imbalances usually aren't too crazy unless you're adding on a diuretic or they're on other medications that can mess up electrolytes. One of the key things for our female populations is that ACE inhibitors are teratogenic. So making sure that if you're going to start one of these medications, that you have that conversation with the families. ARBs, one of the pros is that there is no cough associated with it. It's also renoprotective and cardiac and vascular remodeling. It also affects the kidneys, so you can have some electrolyte abnormalities and is also teratogenic. In terms of calcium channel blockers, they are well tolerated, once daily dosing. They can be helpful for more complex migraines and cluster headaches too. So sometimes I will pick a calcium channel blocker if I have a patient with headache history. Some of the abnormalities is it can cause some edema, flushing, and headaches. So it's kind of funny that it can be migraine helpful, but also can cause some headaches. But I've had some good success in kids with migraines starting calcium channel blockers and their headaches improve. Not always. And then thiazide diuretics and beta blockers, we don't use them as frequently, but they can be helpful in certain situations. Early intervention. The reason that we do this in peds is that we do have some strong evidence to show that early intervention helps. So DASH diet, reducing sodium, there's some good pediatric studies out there to show that it does lower blood pressure in youth with obesity and hypertension. Same with physical activity. The CDAH cohort showed that, and some pediatric exercise studies showed that improved blood pressure trajectories and vascular health has been found in pediatrics with just increasing physical activity. Treatment is super important. Better blood pressure control decreases the LVH risk and proteinuria. And then identification of early risks is important as well. So longitudinal cohort studies have shown that identification can impact lifelong cardiovascular risk by reducing it. So treating risks early can change lifetime cardiovascular, and that's supposed to be outcomes. Sorry, I got cut off. So overall, the take-home message being that pediatric hypertension is common and often cardiometabolic. Diagnosis does depend on accurate blood pressure measurements and confirmation. And then early recognition and treatment can change lifelong cardiovascular risks. So overall, takeaway is just childhood blood pressure does matter because early action is super important. And that is what I have. And I believe there's some questions, and I apologize if they were supposed to be in here if we send them out after.
Oh, no problem. I see a question in here from Amy Garg. It says, is the average blood pressure done at 2 to 3 different visits?
Ideally, yes. If you have a family or like say it's an athlete and timing, you may not be able to get them back in that time frame. You can get one at the beginning of the visit and at the end. Again, we all work in real life situations and not in the ideal world. So if you can bring them back to clinic, that is what the guideline is written for. But in the real world, I have done blood pressures at the beginning of a visit and then a follow up after the kids had some time to relax. Obviously, don't tell them they're going to be getting shots or any other like painful procedures. If you want to get a good blood pressure, like wait till the very end of the visit to do that.
Great. We do have some time for other questions. Let's see. Is there ever a time where we might initiate medications in a primary pediatric clinic, or should we refer to nephrology after initial workup is done?
I would say if you're going to initiate medications, make sure you understand the different medications, their pros and cons, and what the follow-up time frame is and all of that. Um, because at the end of the day, a lot of times if people, I get really frustrated when blood pressure medications are started based on 1 or 2 clinic blood pressures and the kid comes to me, their blood pressure is completely normal. Now they may plus or minus symptoms because of the blood pressure meds we've started and they never got a 24-hour blood pressure monitor. The kid appears anxious. And then it's like, again, you're asking for them to have to come back for multiple appointments or have to stop the meds and have them come back for a 24-hour monitor in a month because I want to make sure the effects of the blood pressure medication are out of their system. So that's a yes and no question or a yes but question. So it really depends on your background, your comfort, the availability that you have to actually be able to do the follow-up and the workup and the confirmation. If you have all of those things in place, then by all means, become a hypertension specialist in your area.
And then
And
on
which
that,
arm do you measure blood
oh,
pressure in? So in my clinic, we actually get blood for all new visits, we get blood pressures in both arms and one leg. So it really is dependent on the patient. For our 24-hour monitors, we use the non-dominant arm because they're still having to exist in their world for 24 hours, go to school, all that stuff. So ideally, if it's high, I would say get it in both. There is vascular tone differences because again, this is not a central blood pressure that we're measuring with the arms. You're really getting a peripheral blood pressure. So I have seen differences between arms in athletes, in some kids who aren't athletes just that day for whatever reason, they have 2 different blood pressures in their arms. So if it's high, I would encourage you to yes, do it in both arms. If it's normal in one, you're good. So yeah, I think it's whatever works the best in your clinic. And then Good reference for pediatric blood pressure medication prescribing. I would still probably point you to the 2017 pediatric guidelines. I know it's a hefty document, but it does have some information on blood pressure medication. In terms of, you know, prescribing and everything, really ACE, ARB, calcium channel blocker, you're really not going to go wrong with choosing any of those unless you have a adolescent teenage girl who doesn't want to protect herself from getting pregnant, then definitely go with the calcium channel blocker. Please don't start beta blockers unless you have a really good reason to. Especially in athletes, you're just going to cause them more fatigue and problems. So start low, go slow. Don't hit them with adult doses. That would be my biggest recommendations. And then for diagnosis, do you need a renal ultrasound along with the monitor? That's a yes if answer. So in younger kids, especially that less than 6, because renal causes are the most common, then we definitely get renal ultrasounds. I will also get renal ultrasounds in anybody with a history of recurrent urinary tract infections, anybody who has a history of an abnormal renal ultrasound, like in childhood or like infancy. I will get a repeat. Um, Really, for me, I tend to err on the less than 10. I'm going to get an ultrasound. Some hypertension providers get them on everybody they confirm hypertension in because they're worried about those renal arteries. Um, for me, if they're not responding to medications in the way that I would expect, then I definitely get a renal ultrasound. If I'm adding a second agent on and don't see the effect of the meds as I would suspect, I'm going to get a renal ultrasound. So that's kind of, it's a less than 6, yes. 6 and above is kind of a gray area and really depends on their clinical background. And there's been some more research and data in the world of urology and nephrology with reflux, and likely that it's probably causing some scarring that is subclinical and not going to be picked up on a renal ultrasound. That probably has some effects later in life too. So there are people looking at that more and more. But unfortunately, to really understand the scarring, you have to take a biopsy or do some other specialized testing, which you're not going to pick up with an ultrasound. So I think more so just having that history and keeping a closer eye on kids who have that history of UR or prematurity or frequent urinary tract infections. Those are going to be the kids that I probably am going to keep a closer eye on. Um, and then we have debate in our outpatient clinic how early often to get on our preemies who didn't have a significant interest or intervention in NICU or yeah, so if there are blood pressure numbers based on prematurity, um, in terms of like what's the 90th percentile and like what blood pressure cutoffs are based on how early they were born. So in that first year of life, there's some data out there. I don't have the reference memorized in my head, but if you just look up pediatric blood pressure normative values in premature infants, you should be able to find the paper. Um, and anytime it's elevated, you should treat if you like confirm on multiple visits. And the thing is, a lot of times the premature infants may have to be on blood pressure medications for the first couple of years of life, and then you can wean it off. So anytime I start a medication, in my mind, I'm always in the back of my mind, if I see significant shifts down on the same dose or want to trial somebody off of medications, that's always an option because heart disease takes decades to develop. So in the time frame of a year of trialing off meds and repeating studies and repeating blood pressures, it's not going to have a huge negative impact long term. So if you are treating the blood pressure and then in a year or two that child comes back and their blood pressure looks amazing, you can start weaning the blood pressure meds down or potentially just take them off and recheck later on. Um, I hope that answers your question, but in my opinion, it's never too early to target the blood pressures to save the arteries. And then, how often do you follow urine microalbumin or albumin in patients on meds? I actually don't follow that. However, the historically in at least essential hypertension, the urine albumin has not panned out in any of these like long-term cardiovascular studies per se. But where it is becoming a huge topic is in the metabolic world. So in our obese populations, the cardiovascular kidney metabolic syndrome is the big hot topic in cardiovascular health. So it's definitely changed my opinion on who I may start to get urines on. But in terms of management, it doesn't really change mine. Uh, Now, if they have kidney disease or other renal issues that you're following, that's a completely different story than just essential hypertension. So I hope that helps your question too. All great questions. And again, my email was in the slides, and I think they send the slides out. So if anything does come up, and obviously, I'm assuming most of you are in Ohio because this is Ohio based. I do have a medical license in Ohio, Kentucky, and Indiana. We do telemed for our lipid clinic. So if you have a hypertensive patient, you live far away from Cincinnati Children's, and you're just like, what are my options for this kid? We can also try to work with you guys to help get them to the right places. Um, there's a few other preventive cardiologists in the state of Ohio as well, so pediatric people. So I can also connect you with them if you live closer to those locations. But I've got some kids where, yes, I make them drive to Cincy for those first couple visits to just confirm the diagnosis, get the medication started. And then I have some hypertensive patients that I see yearly. And then at that 6 month mark, I might have them get a blood pressure closer to home and do a virtual visit with them. So there are some other options. We're trying to get home blood pressure devices a little bit more in use in the pediatric population. So hopefully that'll be an option as well moving forward to monitor and guide treatments. So yeah, so feel free to reach out if you ever need anything. But I guess the biggest takeaways: get good, accurate blood pressures and be measuring blood pressures and those other cardiovascular risk factors in all the other millions of things that you guys are supposed to be paying attention to as well. But again, I couldn't do what I did without a great medical home, and primary care providers are really the go-to for that. So
All right. I think that kind of wraps us up for today. I do want to send a thank you to the Ohio Department of Health as our sponsor, and then to Dr. Henson for a fabulous speech. She did mention that we will post the slides and the video of this webinar on the preventative health page, which I'll send the link to in the email I send on Monday. And that will also include your link for applying for CME credit. If you have any questions about the preventative health program, feel free to reach out to me. Otherwise, I hope you all have a great weekend, and we will see you next time. Thank you.
yes,
Thank you.
and thank you so much. And oh, one other thing, if there's any feedback, if there was anything that was confusing, like please let me know. I want to make this as helpful as possible. So if I use terms or things on my slides didn't make sense, like let me know and I will definitely adjust them.
We will. Thank you.
Thanks, Sarah. That was great.